Wake up. It's the Sleep Unplugged podcast, episode 78, Central Sleep Apnea. Let me catch my breath to breathe. Welcome, everyone, to the Sleep Unplugged podcast. My name is Chris Winter. I'm your host and sleep specialist. Very happy you're here. If you're new to the Sleep Unplugged podcast, welcome. Glad you could join us. If you're a veteran of the podcast, welcome back. There's been some discussion. This was actually a podcast episode that was recommended by a listener a few weeks back. And it's definitely a topic that is confusing. It's confusing, I think, to sleep specialists. One of the articles I was reading was why why central sleep apnea is so misunderstood, even within the sleep community. So I thought it deserved its own podcast and at least some discussion. So I hope you'll enjoy that. So excited you're here. If you want to communicate with the show like the listener did who suggested this topic, you can get in touch with us at Dr. Chris Winter on Twitter, Dr. Chris Winter Instagram, Dr. Chris Winter TikTok, Bluesky, and Threads. We have a Sleep Unplugged podcast page where we upload all the videos of our content, and you can interact with us there as well too. Excited about next week's episode, and we'll do some advertising of it on our social media leading up to it. It's our yearly award show, and I really like it because it's a fun time to take a break from our typical content and really point you all in the direction of amazing sleep specialists and sleep people who are writing books and putting excellent content out there in social media and doing all kinds of things behind the scenes to protect and preserve your sleep. So I think last year we had a Sleep Book of the Year award. We had a social media warrior, the individual out there giving the best insomnia advice, sort of a sleep outsider, somebody not really in the field of sleep who's doing cool things in sleep. We had a sleep vanguard organization, a sleep crusader, and I think we'll add a few new categories this year. One that I definitely want to do is recognizing other awesome sleep podcasts. So tune in next week. That'll be released, I guess, on midnight on the 25th. Christmas Day. So that'll be our final episode of the year. We always do our Sleep Awards final episode of the year. We always like to start the show off with comments, corrections, criticisms. 2 comments about last week's episode on sleep trackers. Eric wrote, "What do you recommend doing with my sleep tracker when I soon have a newborn baby? I would put that away. Not because it's a choking hazard. Very well could be because you might not like what you see." I'm kidding. I think it'd be interesting, Eric, for you to actually wear it. Wear it now. How much sleep are you getting? What are your typical sleep scores? And what do they look like when you have the newborn? And what I would do is make a prediction. If you're somebody who consistently scores a 90 out of 100 on your sleep score, I want you to write me, and I want you to predict what you think your average score is going to be when the new bundle of joy arrives. And then you can let us know as time passes if your prediction was worse than it turned out to be, better, more optimistic than it turned out to be. Our listeners want to know, what is the sleep cost of adding children to your household? So Eric's going to let us know about that. Good luck, Eric. We wish you all the best here from Sleep Unplugged, that you get a little baby who enjoys sleeping and is really good at it. Annika wrote, "I'm excited for the episode. Just started using a sleep tracker for the first time. The data is interesting. I need to learn about the details of wearing it on different hands." So I'm not sure if you were kidding or not, but I was when I made that little post about I wear sleep trackers on the left and right side of my body to see how the different halves of my body are sleeping. I was just kidding. But, there are reasons to wear it on different arms. Wearing a sleep tracker on your non-dominant arm might eliminate some bad information. Like if you wake up and scratch your face or you're messing around with something, you're probably going to use that with your dominant arm. So putting it on your non-dominant arm might be helpful. You also mentioned, Annika, which is a good point. You sleep on one side or not, because she mentioned having a deviated septum. If you're wearing it on your left side and you sleep on your left side, if your device has a pulse oximeter feature, sleeping on your left side with your pulse ox on your left side, you might actually sleep on your arm and cut the circulation off to your arm and might get some false readings in terms of your pulse oximetry data. One thing that you can do is to move the device around from your wrist to your ankle. I have had patients talk about when I wear it on my wrist, I get better scores. If I switch it to my ankle, they're significantly worse. And I've always wondered if that might be a good way to sort of get a sense of whether or not you have some periodic leg movements during the night. So if you're wearing it on your arm and always score in the 90s and get smiley faces, and put it on your ankle and score 30s and get frowny faces, it might indicate that your legs are moving when your upper extremities are not. So left or right probably doesn't make a big difference, but maybe upper half of the body, lower half could. Eric and Annika, thank you so much for listening to the show and interacting with it. We really appreciate it. We always start the show off with music. And this week, the music is from Pearl Jam. And there's actually, this is a lyric from a Pearl Jam song that I really like. The Let Me Catch My Breath to Breathe is a line from their song Sirens, which was off of their 10th album. It was the second single off their 10th album, Lightning Bolt. And Pearl Jam is one of those groups, kind of came out when I was in late high school, early college. The grunge movement, everybody knows about their first album and their subsequent albums, Vitology and Yield. And Pearl Jam was one of those groups that I just kind of lost track of over time. But every time they put an album out, there was really something great on it and something different. So Lightning Bolt was their 10th album. It was released in 2013. Again, Sirens is one of my favorite songs that they do. And that was a beautiful song and a beautiful vocal by Eddie Vedder. Their most recent album, Gigatron, had Dance of the Clairvoyants, which I thought was really a unique song and really progressive for the group. The album prior to Lightning Bolt was Backspacer. And in keeping with our theme of breathing, the second single from that album was a song called Just Breathe. And it's absolutely gorgeous. I think it was actually the first song of Pearl Jam's. It was actually certified platinum. And there's a great rendition that he does with Lucas Nelson, Willie Nelson's son. You can find it on YouTube. I think actually Willie Nelson covered the song. It's just a gorgeous, gorgeous song. And I'm a really, really big fan of this song. Just Breathe actually was inspired by Eddie Vedder's work on the 2007 soundtrack for Into the Wild, which I think is one of the most underrated and underappreciated soundtracks out there. It's gorgeous. It is one of those soundtracks that sort of goes with the movie, kind of like the Graduate soundtrack. It made that movie, or maybe even something like Good Will Hunting and Elliott Smith's work. So salute to Pearl Jam. It's the first time we've talked about them on this show, and we'll put both of their songs, Sirens and the lyric from the title, but also I think we should put Just Breathe, since we're talking about breathing. We'll put most of those on our Spotify playlist. So if you listen to this podcast, we put all the music that we talk about on the Sleep Unplugged Spotify playlist, Volume 2. You can find that wherever. If you have Spotify, you can follow that playlist and be aware of all the music we put on there. So let's talk about central sleep apnea. We've talked several episodes about sleep apnea. One of our very first episodes, episode 5, we talked about a mild sleep apnea. That was our death by CPAP episode. But we've talked about treatments for sleep apnea and more significant sleep apnea in later episodes, which I think were really important. We've also talked about snoring in episode 29. So sleep apnea is important, but as one of our listeners pointed out, he basically said, look, you're always talking, severe sleep apnea was episode 42. He said, you're always talking about obstructive sleep apnea. You don't really talk a lot about central. And that listener was right. Obstructive sleep apnea is what we typically talk about. It's what's most commonly seen out there, where an individual has all the abilities to breathe, but their airway is collapsing. So you can imagine obstructive sleep apnea, as the title would describe. There is something obstructing that individual's ability to breathe. Generally speaking, it has to do with upper airway tone, where the upper airway is collapsing in a way that makes it difficult to move air from the environment into your lungs. It is a cave collapse. The minors are in the cave. The entrance to the cave is collapsed. Everything about the cave and the miners is working fine. They just can't get food and supplies into the cave because of now the obstruction. Versus a central sleep apnea is where the miners just don't want to enter or exit the cave for no real particular reason. Maybe they're worried that the cave will collapse. Maybe they found other employment. Maybe the cave conditions are so lovely that they don't want to go back out into the real world. So central sleep apnea is a completely different beast, where the mechanisms that control breathing start to become disrupted. And there's an instability in that body's feedback. So when we breathe, lots of things are happening, and they're all happening to some degree behind the scenes. As we breathe in, there are receptors in our body that are measuring the amount of oxygen, and in particular, the amount of carbon dioxide in the blood. And that information is being relayed to a part of the brain called the pons and the medulla. So in that part of the brain, the chemical nature of oxygen and carbon dioxide in the blood is being measured and evaluated, and adjustments to breathing are being made. So you can imagine, if the oxygen levels are low and carbon dioxide levels are high, there is going to be a signal to increase breathing, the rate or depth of breathing. Similarly, if oxygen levels are very high and carbon dioxide levels are very low, you're going to get the opposite, more of a suppression of respiration. And this, and we all are aware of this. If when you were a high school student, you may have done, the thing where you kind of breathe in, you hyperventilate for a period of time, and all of a sudden you kind of start to, get a little dizzy or whatnot, because you're actually changing the amount of oxygen and carbon dioxide in the blood. Or so we see those things sometimes in action when we're kind of playing around with those things. You might even pass out in some ways, and that all has to do with the chemoreceptors and the processing and regulation of our body's ability to breathe, and keeping oxygen and carbon dioxide at stable levels. So when we think about these things, a common group of individuals that we think about a lot when it comes to the control of respiration are little babies, particularly premature babies. When we think about things like sudden infant death syndrome, SIDS, we think about a baby that is born prematurely and their brain is not fully baked. So the parts of the brain that are responsible for controlling breathing might not be fully formed yet. So these are babies that are having difficulty breathing, not because something is obstructing their breathing, but because the mechanisms for controlling the breathing can become problematic, can become disturbed. And so that's why when you have a premature baby, they're often sent home, or they're kept in the hospital and monitored, or they're sent home with devices that allow them to monitor breathing, monitor their oxygen levels. And there's alarms that go off if those things become disturbed, because that chemoreceptor feedback to the brain is not fully online yet. So setting babies aside, let's think about why adults would have that. And like I said before, this is a condition that is much less frequent than we see in the obstructive apnea that we see in adults. And I think that's really important, because as a sleep clinician, I often get patients who've come to me having had their sleep evaluation somewhere else. And so we have to keep in mind that, number one, central sleep apnea is relatively rare. And number two, it's often indicative of some more serious medical concerns. So when a perfectly healthy 30-year-old comes to me with severe central sleep apnea, on a bi-level device, which is not terribly uncommon, it always begs the question, why do you have this? So I always ask the question, when you had this evaluation, what were you told? Generally, they're told nothing. Like, I don't know. They told me I had really bad central apnea and put me on this more elaborate breathing device. So often these individuals are put on bi-level devices that have a specific pressure when you breathe in and breathe out, and often help with the process of breathing. They can trigger breaths themselves. So they're much more elaborate than the typical CPAP, continuous positive airway pressure, that's simply being used for individuals with obstructive apnea, where it props the airway open with pressure. So you can think of a CPAP, generally, it's just an airway splint. This individual's mechanisms for breathing are perfectly fine. We just need to prop the airway open to allow it to happen. In central apnea, the airway's open. There's nothing that needs to be propped open. Their brains are choosing not to breathe. That's the central apnea. So a CPAP generally for an individual with central apnea is not particularly helpful. So back to the 30-year-old triathlete who had a sleep study and now is in my clinic because some things are going on with their sleep, and they're on a bi-level device for their severe central apnea. My first question is, why do you have severe central apnea? So I'm going to take a step back and go through the sleep studies. When we typically diagnose sleep apnea, individuals are having a sleep study. And we've talked about sleep studies before. So you go into a lab or you do this through your own home. And the basic components of diagnosing sleep apnea are, we're doing something to measure sleep. And we talked about that with consumer tech last week, that measuring sleep is not a particularly easy endeavor. And sometimes home sleep studies don't do that quite as well as the in-lab study. So this individual is having an in-lab study. So we've got the electrodes on their head to measure their sleep, but we need to measure breathing. And so that's typically done with something around the nose and mouth to measure the amount of air that's being moved from the nose and mouth. So we can actually see breathing. As that individual breathes out, the little tracing goes up. As they breathe in, it goes down. So we can see in, out, all through the night, the amount the individual's breathing. We can also see their oxygen level and generally their carbon dioxide level based upon monitors that we have on individuals. So we can actually see the amount of CO2 that they're breathing out, the amount of oxygen in their blood. And when an individual stops breathing, either from a central apnea or an obstructive apnea, we can see that oxygen level go down. Now, a very, very important component to the sleep study that allows us to differentiate central and obstructive are these bands that are generally put across the chest and abdomen. So as the individual breathes in and expands their chest, we get a movement of the needle. And when they breathe out and the chest collapses, we get an opposite movement of the needle. So as the chest goes in and out, we have a pin going up, down, up, down. So we can see during the sleep study, the individual is actually making efforts to breathe. So think about the up, down of the needle showing the amount of air moving through the nose and mouth. So we're going to see that go up, down, and all of a sudden it becomes flat. What is that telling us? It's telling us that an individual has stopped breathing, or that individual's little monitor has moved to a place where it's no longer able to pick up the air moving in and out. This really gets to the heart of why it is important in some cases to have a technologist monitor a test versus a home test where you set all this up yourself and pray all the monitors stay in place the way they should. Now, obviously, if that monitor from the nose and mouth gets knocked off and there's no movement for the next 4 hours, we're going to think, what if two things has happened? Something extremely serious and tragic has happened, or much more commonly, oh, no, the person's fine. They just knocked it away from their mouth, so it was no longer picking up air movement. Okay, let's imagine that little probe stays in place perfectly throughout the night. Now we turn our attention to the bands across the chest and abdomen. So imagine seeing that probe near the nose and mouth become flatline. That person has stopped breathing. Maybe they stopped for 20 seconds. and then they start breathing again. Now, during that time where there's no air moving from the nose and mouth, or limited air moving from the nose and mouth, what are the chest and abdomen bands doing? If they're working like crazy, imagine what that means. A person can't move air, but they are trying to move air. Imagine somebody walking up behind you as a joke and putting their hand across your nose and mouth. You're going to work to breathe. You're trying to breathe. You just can't get air past that person's hand. Now, imagine seeing that tracing where there is no movement from the nose and mouth and no movement from the chest and abdomen. That individual has stopped breathing and they're not trying to breathe. They're essentially holding their breath. And that is the fundamental way we typically differentiate a central apnea from an obstructive apnea. And you can get into the weeds with the definitions of this kind of stuff. I'll leave that to another sleep specialist. But just in the broadest of strokes, that's what we're doing. So if we look at a sleep study and the individual is constantly having periods where they're not moving air from their nose and mouth, and constantly during those periods are showing no effort to move air, that's an individual having lots and lots of central sleep apneas. And you can have a mixture of them. So even within the same breathing disturbance, there can be a mixture of obstructive and central elements. So imagine a sleep study where the individual gets hooked up and early in the night, those bands become loose or slip from where they're supposed to be. Now they're just kind of pooling around the person's midsection or something of that nature. And there is no technologist following the study, or that technologist is not recognizing that and doing something about it. What's going to happen is that person's obstructive events, where they are making efforts to breathe, are not going to be measured, and it's going to look like a night full of central apneas, which is where I think a lot of times the 30-year-old triathlete who's been diagnosed 5 years ago with terrible central sleep apnea, could they have it? Sure, they could have central sleep apnea. But what's most likely is it was a problem with the technical aspect of the study that's diagnosing them with a condition that they don't really have. So we have to be very careful with that diagnosis when we make it, because it's pretty rare. And when we make it, I think we should probably be questioning it a little bit. So when we look at this individual, what do they behave like at night? Well, a lot of times these individuals are having these central events at night and have no idea they're having it. Occasionally, they will wake up during these events, and it's often a pretty scary event. You know, they're waking up, their brain is to some degree deprived of oxygen. They've stopped breathing. They're this kind of central element to their apnea. They wake up and can feel like they can't breathe. That's not always, but they certainly can experience this sometimes. Usually it's a bed partner, a caregiver, a parent saying, when I watch them sleep, I can count 22 seconds sometimes of them not breathing, and they're just kind of sitting there like they don't want to breathe. And all of a sudden they'll start breathing. You can certainly see this very commonly in individuals with heart disease. You can also see it in individuals who are taking drugs and are intoxicated with a lot of alcohol, because the chemicals that they've ingested are interfering with that feedback mechanism of breathing, which can always be kind of a scary thing. So when we look at individuals who have central sleep apnea, we can divide them into some different categories. One is primary, meaning that of all the different categories I'm getting ready to talk about, none of those apply. They just have central sleep apnea. And I think you can often see that in individuals, like the baby we were talking about, where they're not fully formed their respiratory centers, that they're having a primary central apnea that hopefully over time will get better. Another one we talk about a lot is something called Cheyne-Stokes respiration, where you see a central apnea that is preceded by breaths that get smaller and smaller and smaller and smaller, and then they stop. And there's a period of time of no breathing and no effort to breathe. And then the breathing starts again, smaller, bigger, 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 smaller, 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 stop. So we often call it crescendo, decrescendo breathing. And when I was a medical student and a resident, when you see it and hear it, you can't unsee it and unhear it, meaning that every time I would go into a patient room, you could actually see the tracings of their breathing often on monitors. And it was very easy to spot those people because you could see the line, the breathing up, down, higher, higher, lower, lower, lower. And then they would flatline, an alarm would go off, and then they would start breathing again. When you look at the patient, they were just sitting there. There was no effort to try to breathe like you would see in somebody with obstructive sleep apnea, where they're thrashing, moving around. You can see their chest flailing, trying to get that breath through that obstructed airway. When we think about Cheyne-Stokes breathing, heart failure is a big one. Why heart failure? Why would heart failure have anything to do with breathing? There's lots of different reasons. But if you think about heart failure primarily is a heart that is failing. It is not pumping blood out with the same efficiency as a normal heart. So as you're pumping that blood out at a slower, less efficient rate, by the time the chemoreceptors are figuring out, hey, you know what, this blood does not have, has too much oxygen or not enough oxygen, by the time that feedback loop gets to the brain and adjustments are made with the heart's rate of pumping, it's too slow. So what you get is a slower correction. So by the time the heart figures out there's not enough oxygen and too much carbon dioxide, we need to increase breathing, and it finally does that, it's overcorrected at that point. It's sort of like, what's the analogy? It's kind of like somebody, very sort of near to us on a road, and they're in charge of sort of determining traffic for the toll booth that's coming up. If there's the greater the distance between that traffic determinator, whatever you want to call them, and the toll booth, that feedback becomes problem. By the time the toll booth says, hey, there's way too much traffic on this road, you need to divert. If that message takes too long or the distance is too far from that person who's in charge of the traffic, you start to kind of create more of a traffic mess versus if that message gets sent very quickly. So when there's a delay in that message in the brain, by the time that delay happens, you've overcorrected. Now we've got to slow down breathing. Now we've got to speed up breathing and back and forth. And that's why you get that breathing higher, 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 lower, 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 stop, lower, 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 higher, 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 lower, 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 stop, because it's a constant state of over and under correction based upon that length of time with the heart failure. You can also see this in kidney failure. You can see it in organic brain disease, post-stroke, increased intracranial pressure, like after head trauma. Narcotic poisoning is the place where we typically see it the most, at least I do, where you're watching somebody who's taking a lot of pain medications, and those pain medications are blunting that response to hypercapnia, which is a fancy word for increased carbon dioxide, or hypoxia, lower oxygen. High altitude is another cause for central apnea. There's lower oxygen amounts in the air that you breathe. So you get that sort of same kind of hyperventilation, hypoventilation cycle that you often see, which is why a lot of people don't sleep and breathe particularly well at higher altitudes. Something we call obesity hypoventilation syndrome. There's central sleep apnea due to medical conditions, and then central sleep apnea due to medications and substances we typically take, which we often refer, opioids are the big one we see with that one. And then there's a final one where, ironically, the use of CPAPs to treat sleep apnea can sometimes cause a mixed, or what we call treatment emergent central apnea. And you often see that in people with more significant sleep apnea, that as you treat that obstructive sleep apnea, for the first time, these people, have 98 breathing problems per hour, and they've had it for years. And you put them on a CPAP and suddenly correct their ventilation problem that they have at night. Their brain is sort of used to operating in that sort of low oxygen, high carbon dioxide state. So the sudden correction of that can often create a usually temporary sort of central apnea situation with the initial treatment of sleep apnea. So how do we treat central sleep apnea? This is difficult. And, I'm a neurologist who deals in sleep. one of the lovely things about sleep medicine is that it encompasses so many different specialties. There's neurologists, there's pulmonologists, there's doctors of internal medicine, pediatricians, ENTs, dentists, psychiatrists and psychologists, so many seats, pediatricians, so many seats at the table. When you look at complicated central apnea, to me, this is the domain of the pulmonary sleep doctor. I give pulmonologists a hard time, but they're the ones who are often dealing with this most effectively. And again, that's not to say that the neurology doctor that you see, she's not doing an amazing job treating your central sleep apnea, but it's a confusing topic and one that often involves a lot of math and a lot of ventilation. So one of the ways we can treat it is we can use supplemental oxygen. So when you're using a CPAP, there is no oxygen involved typically. It is typically room air that's being pumped in through a device, a pressure to prop your airway open. There is no oxygen outside of the 20% oxygen in the room air that you're breathing. So when we can add supplemental oxygen, that can sometimes be helpful for individuals who are not what we call non-hypercapnic, meaning that they don't have elevated levels of carbon dioxide. And so people with non-hypercapnic central apnea who have what we call heightened sensitivity can benefit sometimes by giving a little bit of oxygen therapy with or without some sort of CPAP device. Conversely, we can also use a little bit of added carbon dioxide. So if a normal individual is given CO2, and we did a sleep study, we did research studies on normal patients and had them breathing slightly elevated levels of CO2, that your body chemically receives that extra CO2 and says, oh, we've got a little bit of extra CO2 around. That generally means we're not breathing as quickly as we should. So if you hold your breath, what's happening? Your oxygen levels are going down, but your CO2 levels are going up. So when you finally you stop your breath holding situation and start breathing again, you increase your oxygen now that you're breathing, but you're also breathing off CO2. So if we give somebody a little bit of extra carbon dioxide, we can stimulate the breathing process and help some people with central sleep apnea. We also do something what we call non-invasive ventilation. So if you watch your favorite medical TV drama, there's often invasive ventilation, meaning that they stick the laryngoscope down your throat, put a tube down there, and now they can breathe for you, either with the little ambu bag or they hook you up to a ventilator. So the ventilator is basically saying, look, you can't trigger your own breath, but all the mechanisms that allow you to take in oxygen and get rid of carbon dioxide are there and working. You're just not choosing to breathe. So we will breathe for you until that ability is restored. We can do something called non-invasive ventilation with different types of devices that kind of look like CPAP devices, but they're able to trigger breaths. So when you wear them, they can push in a pressure, release a pressure. It can kind of trigger an individual who's using it to help them breathe when they have central apnea. So we can control rates and not allow their rate of breathing to drop below a certain amount. Cardiac improvement. So if an individual has heart failure, improving their cardiac status often dramatically improves their central sleep apnea status. And the same thing for if you're on multiple pain medications, opioids, or drugs that suppress respiration and drugs that cause central apnea or even alcohol, backing off on those medications, particularly prior to going to bed at night, can improve things significantly as well too. Finally, there are what we call respiratory stimulants. One is theophylline, another acetazolamide, which is Diamox. It's a carbonic anhydrase inhibitor. It's the drug that some people will use to help deal with or prevent altitude sickness. I've taken it myself when I was hiking in Peru, and it didn't do a lot. It didn't do a great job. I'll never forget hiking at some crazy altitude, and I was really pretty in shape and got kind of hit on the head by altitude sickness. And it's interesting because it sort of picks and chooses who it's going to affect. Like little kids that were, around me on this hike or whatever, just were passing me like I was going backwards and didn't seem to be affected by it at all. And my daughter Didn't seem to really have a lot of problem with it, but sometimes people use that medication for altitude, and it can be used for central apnea as well too. So that's it. Central apnea, a completely different entity than obstructive sleep apnea and pretty rare. So if you're like, wow, I'm really healthy and was told when I had my sleep study, I have profound central apnea, do you have an understanding of where it's coming from? Did the clinician that did your sleep study offer you any kind of explanation? Do you think perhaps it could be obstructive and you're being treated as having central apnea, which, like I said, I see all the time? These are all kinds of interesting questions to ask your sleep specialist. So that's it. This is the last and final mainstream episode of the Sleep Unplugged 2023 season. I will see you all next week for the 2023 Sleep Unplugged award show. Follow us on Dr. Chris Winter Twitter, Dr. Chris Winter Instagram, Dr. Chris Winter TikTok, and all the other social medias. Follow our YouTube page, subscribe, and follow our Spotify Sleep Unplugged playlist, my books, The Sleep Solution, Why Your Sleep's Broken, How to Fix It, as well as The Rested Child. Sleep Solution definitely talks about central apnea in it. I don't believe we really talked about it that much in The Rested Child. Outside of, we did do a lot about SIDS, which would be a form of central apnea. And we certainly talked about medications as well too. I hope you all have a wonderful holiday season. I look forward to joining you next week. And until then, sleep well.